Greetings, everyone, and welcome to the ECG Case of the Week for the week of February 26, 2018. This is Amal Mattu coming at you from the University of Maryland School of Medicine. Before we get started, I just want to let everybody know about a fantastic free conference that's going to be coming up on our campus Wednesday, March 28th. This is the third annual Emergency Cardiology Symposium. This year's theme is going to be Cardiac Conundrums in Emergency Medicine. Once again, it is free attendance, and we are also going to have free access to live stream. So we're going to live stream the conference. We've got some amazing speakers coming to talk to you and teach you about some confusing and conflicting and controversial topics in emergency medicine. We've got Bill Brady. We've got Suzanne DeMeester. For many of you who may not know Susie, she's one of the rising stars on the CME circuit with the focus on emergency cardiology. And I skipped over Bill. Bill is going to be focusing on low-risk chest pain and some electrocardiography topics. Tarlan Hedayati from Chicago is one of the annual speakers at ACEP every year. She does the ACS talks every year. Dr. Mimi Liu is probably the best speaker in the world, as far as I'm concerned, one of the best speakers, if not the best speaker in the world on pediatric emergency medicine. She's going to be talking about peds cardiac conditions. Who doesn't know Corey Slovis? Corey's been around teaching all of us bread and butter emergency medicine topics for many, many years, and his main area of focus is emergency cardiology, and he's going to be talking about issues pertaining to cardiac arrest. And finally, Peter Pang, who is also from the Midwest, is going to be talking about his area of specialty, which is acute heart failure. He's published some of the real groundbreaking works in terms of emergency management of acute heart failures. So the 6 of these folks are going to be coming to our campus and giving some really, really great talks on emergency cardiology. So don't miss it. If you can be there, that would be great. But if you can't be there, definitely try to check out the live stream. All right, well, let's get into what we're going to spend some time talking about this week. And what exactly is that music? That's the theme song from Jaws. And the reason I'm playing that is because this is what we're going to spend some time talking about this week. And what I hope to emphasize is that when you see this on a 12-lead ECG, you should be thinking about a STEMI, what we're going to refer to as a shark fin STEMI. All right, so let's get into this. So we turn off the music here for just a second. We're going to get started with the case that was sent to us from Stanford by Dr. Dan Shogalev. He was working with the resident, Dr. Alex Zazula, who is a senior resident. They were taking care of a 59-year-old man who came in with chest pain that had occurred during some type of exertion. Now the patient's feeling better. A quick 12-lead ECG is obtained, and this is what you see. Take a good close look at that. Hit your pause button. Do you see anything which is predicting a STEMI or anything else that's bad? Well, it's not a trick question. The answer is no. This looks like a pretty unremarkable 12-lead ECG. Well, Alex, the resident, came out of the room and wasn't all that concerned about the patient, presented the patient to his attending, Dan, who then goes into the room to see the patient and do his own history. And while he's doing his own history, wouldn't you know that the music starts up? And the reason for that is because the patient's now diaphoretic with worsening chest pain, and so he decides to go ahead and get his own 12-lead ECG, and now he is seeing what looks like a big shark fin. In fact, there it is. Take a look at this very strange morphology for the 12-lead ECG, and this is what I refer to as a shark fin STEMI. And I think it's a really cool case. To some of you, this might be a very obvious STEMI, but it's just such an unusual morphology. I thought it was a really cool case to talk about and also show you a few other cases. This morphology, which I'm referring to as shark fin STEMI, has actually been referred to by some others in the literature, or at least on the internet, as a shark fin type of pattern or shark fin STEMI. Sometimes throws people off because what you're looking at is you're looking at a true STEMI, and this is probably the R wave right up there, and all of the rest of that is massive ST segment elevation. That is all ST segment elevation. And in fact, you see some reciprocal ST segment depression in some of these inferior leads. This is a big anterior wall STEMI. So what did they do? Well, they immediately activated the cath lab, and gosh, the patient had a cardiac arrest en route to the cath lab. Fortunately, they defibrillated quickly. Patient made it up to the cath lab and was found to have a 100% LAD occlusion, ended up being successfully stented and walked out of the hospital several days later, but a very near disaster and just kind of an unusual morphology. Well, the first take-home point, of course, that I can't get around is whenever the symptoms change, you've got to repeat the 12-lead ECG. Notice that when the attending goes in, when Dan goes in, the patient is now symptomatic. He wasn't when the resident was there. But now he goes in, the patient's symptoms have changed, so you've got to repeat the 12-lead. Anytime the patient's symptoms get a lot better, get a lot worse, they go away, they come back. When the symptoms are changed, you get a repeat. You might be very surprised at what you end up finding. You might find a life-saving diagnosis. But the other thing that I wanted to focus on this week is this strange, very unusual morphology for ST segment elevation, which we're going to refer to as a shark fin STEMI. And this is something that oftentimes mimics a wide QRS. Sometimes people look at this and think, this is just a big, wide QRS complex. It almost looks like a ventricular rhythm. It's not a ventricular rhythm. This is not VTAC or slow VTAC. It's not hyperkalemia. This is none of the above. This is actually massive ST segment elevation due to the STEMI. So when you see that morphology, don't be misled. You've got to worry that your patient is infarcting right in front of you. And in this particular case, this is a really, really sick patient who coded before even making it to the cath lab. Fortunately, there was a good outcome. We'll share another case with you, also from Stanford. Maybe there's something about Stanford. Well, maybe not. I've got a couple other cases from elsewhere. This case was sent probably about 2 years ago, actually. I'm just showing it now. But it was sent by a couple of former residents from Stanford, Drs. Phi Nguyen and Jia Chang. They have now graduated from the program, but they were, I guess, second-year residents at the time that they sent this. They were taking care of a 37-year-old guy who came in with decreased level of consciousness, and 911 was called because they originally thought that this patient may have had an overdose. When the patient was found by the paramedics, he had some empty bottles of bupropion and olanzapine and lisinopril. When they got there, he was awake. By the time they brought him to the emergency department, he was awake, probably maybe a little bit listless, but he was wakeable. And at the time, now he's complaining of some vague chest pain. So, of course, they get a 12-lead ECG. And once again, here is that strange morphology. Now, in this case, you see the shark fins out here in the inferior leads with reciprocal changes in the anterior leads. So this time, the patient's having an inferior and also a lateral wall STEMI. So you're going to worry about the RCA or the left circumflex. And once again, don't be misled. This is not hyper-K. This is not a wide QRS rhythm. This is just massive ST segment elevation, which is producing that shark fin type of appearance. 10 minutes later, the patient's symptoms get better and the EKG findings resolve. Well, it was very unusual. Apparently, the patient was going in and out of this particular pattern. When he would have symptoms, the shark fins would reappear. When his symptoms would resolve spontaneously, the shark fins would go away. They would dive down under the water, apparently. Initial troponin was 26. They got a quick echo. He had inferior wall hypokinesis with the low EF, and they decided to eventually take him to the cath lab, and no surprise, a 95% right coronary artery blockage, which was successfully stented. So this is another case, unusually, where this shark fin pattern is kind of on and off, just the way it was in the first case. So it's very unusual, but don't be misled. That the fact that it's on and off is not reassuring. It's a very unstable lesion. Here's another case. This was sent by paramedic Rob Perry, also from California. Is this just a California entity? I'm not really sure. 911 was called this time once again for an overdose. They came upon a 37-year-old guy who was pale, diaphoretic, and somewhat slow to respond. Patient admitted to an overdose of lisinopril. So that was kind of interesting when I heard this case. Maybe there's something about lisinopril, because the last case also had some lisinopril on board and some SSRI. So maybe this is some type of overdose pattern. It turns out it's not. But anyway, just a coincidence. When they get there, the patient does have some cardiac risk factors. He's a bit hypotensive, and he's complaining of some chest pain, and his rhythm is changing. Here's the first rhythm, and there's that shark fin once again. Take a look. Very unusual pattern. Out laterally, it's a lot more obvious that this is just ST segment elevation, but if all you saw was a rhythm strip of this stuff, that would be pretty tough to interpret. Fortunately, they had the full 12-lead ECG, and they were fairly sure that this was a STEMI going on. A few minutes later, the rhythm strip changes to this, back to normal, and then a few minutes later, it changes back to this. So once again, 3 cases where the patient is going in and out of this strange morphology. Maybe it's some type of very unstable lesion which occludes and then opens up and occludes and opens up. I'm not exactly sure why this seems to come and go. When the patient was having that wide, complex-looking QRS, he would tend to be more symptomatic. He was more hypotensive, and he tended to have more vomiting. Now, was it the hypotension that was inducing this ischemic pattern or vice versa? I'm not really sure. But bottom line, once again, 3 straight cases where that shark fin appears to be coming and going. The patient arrives in the emergency department, and at arrival, the physicians are really uncertain about whether he's got an overdose-related ECG pattern or whether he's got a STEMI, and maybe that whole overdose is just a red herring. Maybe the overdose has caused so much hypotension that that's making him ischemic. So there was some uncertainty about whether this is actually a STEMI or just an overdose pattern. Well, to get rid of the uncertainty, they sent him off to the cath lab, and he had a 95% RCA blockage and was successfully stented. Let me show you a couple of more examples. This was sent by good friend Todd Haber and one of his colleagues, David Smith. David was actually taking care of this patient that showed up, a 52-year-old woman with diabetes. So now we're on the East Coast, so rest assured this is not just a California entity. 52-year-old woman comes in with diabetes. She's been having chest pain for a few hours. She tried to tough it out and didn't call 911, but then she has a cardiac arrest, so the husband calls 911. Paramedics arrive, and they bring the patient into the emergency department. The patient was initially in ventricular fibrillation, got shocked out of it, back to return of spontaneous circulation. She arrives in the emergency department intubated and hypotensive, and there's your ECG. So once again, kind of maybe a variant of the shark fin pattern. It's not so much curved back like that, like some of the other shark fins. This one is a little bit more of a triangular type of shape, but nevertheless, it was a very unusual type of morphology, maybe a different type of shark going on. Patient ends up going for post-arrest cath, and they found a 100% LAD occlusion. They were able to open it, but unfortunately, the patient had such significant pump failure that she ended up dying a few hours later. And no, this was not hyperkalemia, and there was no overdose involved in this case, no lisinopril involved in this case. This was just a big, bad myocardial infarction, really bad. The patient ended up having a cardiac arrest. And I'll show you one more case that Todd actually sent. This is a different patient. This is a 76-year-old man who also is status post VFib arrest. And here's the post-arrest ECG. This patient, unfortunately, also later died. Once again, you see this more of a triangular type of shark fin appearance. You know, looking at that morphology, I was kind of thinking, well, shark fins tend to be more of that coved pattern rather than straight up and straight down. This pattern almost looks a little bit more like the dorsal fin of a male killer whale. So I was thinking, well, maybe that is really what this should be called. Maybe this is called killer whale STEMI. I don't know. I don't want to go through the entire animal kingdom. I guess we'll just stick with shark fin STEMI. But here's yet one more case, case number 6. And I'm sorry, but I don't actually remember who sent this case to me. It was quite some time ago. If there's any viewers out there that remember that they sent this case to me, please send me an email, take credit for this, and tell me what was going on with this patient. But this is another example of this shark fin or killer whale fin, I don't know what you want to call it, morphology. It's a very, very unusual morphology, and it would be very easy to mistakenly call this hyperkalemia or mistakenly call this a ventricular rhythm, but no, this is a STEMI, and it appears that you've even got some reciprocal depression out there in V1. Not much in terms of reciprocal depression in other leads, but this is absolutely in every way a STEMI. So, quick take-home points about these cases that we talked about. First point I want to make once again, repeat the 12-lead ECG. Anytime symptoms change, repeat the 12 lead, and look for changes. If the pain's getting worse, if the pain's getting better, if the pain goes away, if the pain comes back again, just get a repeat 12 lead ECG, because evolving changes are very, very important and help direct your workup and make the diagnosis of acute coronary syndrome much more likely. And every now and then, that repeat ECG will actually show you evidence of a STEMI, and then your management, of course, completely changes. And then, with regards to that shark fin STEMI, remember, when you see that shark fin, be worried that you're looking at a big STEMI, and in all these cases, the pattern seems to change quite a bit. It comes and goes, and a few of these cases even had cardiac arrest. Don't mistake this for a wide QRS, VTAC, or hyperkalemia. This is a massive STEMI. Don't miss this shark fin. All right, well, my thanks to everybody that sent me these cases with this pretty cool, unusual type of STEMI pattern, shark fin STEMI. Be on the lookout for it. If you come across any of these, well, stay out of the water, I guess. All right, folks, well, that's it for this week. I hope this cases have been helpful, and I look forward to talking to all of you next week. Bye for now. Well, hey, folks, I'm back, and just a few extra words about this whole shark fin STEMI deal. Coincidentally, just a few days after I finished this recording, I saw an article published in Journal of Electrocardiology that was focused on what these authors referred to as a triangular QRS STT waveform, and it is exactly the shark fin STEMI. So go figure. I'd never seen a publication on this before, but within a week of finishing our little discussion, there's a publication on shark fin STEMI, and they talk about this giant R wave and the steep down-going ST segment. Theirs is not as shark finny as our cases were, but nevertheless, it's really discussing the same thing. They actually did a study, and it was a somewhat interesting set of results. Not surprising, though. They looked at 367 patients with STEMI, 5 of whom had that pattern. It's only about 1.4%, so it's a relatively rare pattern, but it does show up, and these are really sick patients. 2 out of 4 that had a cath ended up having left main coronary artery involvement. I'm assuming the one that didn't have the cath ended up dying. 5 out of 5 of these patients developed VFib, 4 out of 5 developed cardiogenic shock, and 2 out of the 5 died. And those numbers are fairly similar to the cases that we presented. A couple of them had VFib and ended up, unfortunately, dying. So these are very, very sick patients. Their conclusion was very simple and straightforward. When you see the shark fin STEMI, or the triangular morphology as they refer to, it reflects a large area of transmural infarction. It's a predictor of cardiogenic shock. These patients have a high in-hospital mortality, and the bottom line is you need to be very aggressive, and early mechanical support is often needed. I don't think that's going to really change our management very much. As long as you recognize that these patients are STEMI, you're going to do everything the way you always manage STEMIs. You're pretty aggressive with all of these patients to start with, but you need to make sure that your inpatient physicians know that this is a special type of STEMI that really has a fairly bad outcome. So anyway, just wanted to present that little extra bit of literature for you, and with that, we are now done. So I look forward to talking to all of you next week. Bye for now.